As a sleep doctor, I do not recommend medications for chronic insomnia. Let's look at why. Today we're talking about why sleeping pills don't work. If you are a physician who wants to uplevel your sleep medicine knowledge, go ahead and subscribe to this channel. I'm Dr. Nishi Bhopal. I'm a physician board certified in sleep medicine and integrative psychiatry. This channel is for you, the physician and healthcare practitioner who wants to learn more about sleep. And before we jump in, I'd like to invite you to get my free melatonin brand guide. It's your guide to third-party tested melatonin supplements because quality really matters. So if you are ever recommending melatonin to your patients, you need to be using third-party tested supplements. You can get more information about that in my free guide at IntraBalance.com/melatonin. I get questions all the time from patients and from colleagues about sleeping pills. They'll ask me which ones are the best. What do you think about the new orexin antagonists? What do you think about Melatonin? What about using quetiapine or trazodone or these other off-label medications? How about using doxepin or hydroxyzine? So I get questions like this all the time. And here's what I tell people is that I actually do not recommend using medications for chronic insomnia. There is a role for medications to be used short-term in the right situations, but when patients have chronic insomnia, which is defined as difficulty falling asleep or staying asleep at least 3 nights a week for 3 months, sleeping pills don't fix the problem, and in fact, they can make the problem worse. The question to ask is, why are they not sleeping in the first place? And the most common reason for chronic insomnia is hyperarousal, right? Patients don't feel sleepy. Their sleep drive is masked by hyperarousal. They feel wired, they feel on edge, it's hard for them to relax, it's hard for them to fall asleep because they cannot access their sleep drive. One of the ways that I conceptualize chronic insomnia is that for many patients, it becomes a phobia of being awake at night. Sleeping pills, whether they're prescription sleep aids or over-the-counter, don't really get to that hyper. In fact, sleeping pills can sometimes become a perpetuating factor that keeps people stuck in the cycle of insomnia. How many times have you had patients tell you that this sleeping pill stopped working, so can we try another one? Or let's try this one, let's try a different sleep aid. Do you go through those cycles of different sleeping pills with your patients? Let me know in the comments if you do experience that. In fact, I've had lots of patients come to me with a laundry list of sleeping pills that they've tried and failed, and they're hoping for the next one that's going to give them the breakthrough. As research is evolving, we're learning even more about sleeping pills and the negative impacts they can have. And just a couple of weeks ago, there was a study on zolpidem or Ambien showing that it impairs glymphatic clearance. It reduces the brain's ability to remove waste products and toxins during the night, which is an important aspect of sleep. Here's the real trap. Sleeping pills might work at first because they provide patients with a little bit of reduced anxiety, a bit of reduced hyperarousal so they can access that sleep drive, but over time they start to build a tolerance. So they need higher doses, or now they feel like they can't sleep without the sleeping pill. This then leads to a cycle of dependence. They may psychologically or physiologically depend on the medication, and then when they try to stop the medication, they may experience withdrawal or rebound insomnia, which then reinforces this idea that I need this pill to sleep. And the tragic part of this is it reduces the patient's confidence in their ability to sleep. Their sleep confidence diminishes. The real alternative to sleeping pills for chronic insomnia is CBTI, or cognitive behavioral therapy for insomnia. That gets to the root causes of insomnia. It's the first-line treatment recommended by the AASM, or the American Academy of Sleep Medicine. In fact, if you look at the AASM guidelines for treatment of chronic insomnia, the medication recommendations are all deemed weak recommendations, and they are second line and only to be used in certain situations, but CBTI is the gold standard first-line treatment. So my approach with integrative sleep medicine is to use those core principles of CBTI and bringing in other practices that support that. And there is data supporting the use of third wave therapies like ACT, or acceptance and commitment therapy, and mindfulness alongside CBTI. This can be done in a really personalized way that's even more effective. What I love about treating chronic insomnia is that it's so highly treatable without medications, and in fact, patients sleep better when you're able to get them off of these medications. In the next video, I'm going to talk about my approach to tapering off sleeping pills.